Good morning, Boquete. Good morning, Chiriqui. Good morning, Bolivar.
Good morning.
Our engineer for today's show. Good morning, Veronica and David. This is Talking with Your Doctor with Dr. Shannon Tour, coming at you live on Radio Chiriqui 103.3 FM. I have today my guest. My co-host today is Al Stefanelli.
Buenos días.
And my guest today is Dr. Digna Diaz. She is a specialist in internal medicine as well as aesthetic medicine.
Yeah.
She is here to talk to us today about a little bit about preventive medicine. Now we'll go into what preventive medicine is exactly, but I would also like to mention today is September 11th. It is the 20th anniversary of the attacks on the World Trade Center. So, just wanted to mention that. It was a terrible day in history, and 20 years out, and we're still trying to figure things out.
Día muy sombrío.
It was very unreal. It's still unreal. Also, I want to wish a very happy birthday to my mother. It's her birthday tomorrow. Happy birthday, Mom.
Happy birthday. No, you don't want to hear that.
So welcome, Dr. Digna.
Thank you, Shannon.
I think most everybody knows you in this town.
Okay. Yeah, I've been here for a while now.
You've been here for a while, and you've seen probably...
Everybody.
Everybody in town.
I don't know if that's true, but a lot.
Most of the people in town
yeah.
at least know of you.
Mhm.
So talk to us a little bit about preventive medicine. What exactly is preventive medicine?
Well, preventive medicine, it's the care that you take as a patient to go and check your blood, your stool, your urine, do general checkups in advance.
Okay.
Especially if you have some risk factors or known history in your family of some diseases, you go with time and you do your regular checkups. So if you're developing something, you catch it on time, and there are better chances of
treatment.
Right. Exactly.
So basically, it's like doing as an adult the well baby check. You're not feeling sick. You don't have a cold. You don't have pneumonia, but you should do like your yearly health control.
Exactly, and this is difficult for some patients or some people because they feel well, so they say, "Why should I spend that money?" It's not an expense. It's actually an investment on yourself.
Right.
And it's only once a year you go with the metabolic panel. That's what they call it on the States.
That's what they call it. It's a lot of tests.
A lot of tests involved, and a physical. The physical is key and very important because sometimes you have labs, but as we say in internal medicine, you have a patient. You have to touch them. You have to see them. You have to listen to them. And just from that, you will get at least 50% of your diagnosis, and hopefully in time.
Right. And we tend to specialize the laboratories depending on what the patient also tells us. So you might bring us what you think is a complete blood panel for us to interpret and tell you what's wrong, or if you have any problems, but it's missing some things sometimes.
Yeah, that happens, especially in the first one, in the first appointment. Of course, some patients know what to get, some others don't. I've seen that in the States, they're used to go to the laboratory and ask for a metabolic panel. That doesn't happen here. So the Panamanian physicians, we send the general ones, the ones that we call the screening tests.
Right.
And then from there, we see you in the clinic and the appointments, and then we do the checkup. The best case scenario is that your physical is normal, you don't need to add anything else. But if we do find something either in your history, medical history, or the physical, then there should be some other tests added.
Is it very important that somebody share also their family history?
Oh, it is very important. The whole medical history it's very important, and it consists on the family history, on your non-pathological, ¿cómo se dice antecedentes?
Your history.
A non-pathological history. This meaning smoking, drinking, drugs, allergies. Your pathological history, high blood pressure, diabetes, etc. Surgeries. If you're a female, your pregnancies, histories, your prevention methods, etc., and traumatic history also.
Right. We need to know a lot of information to be able to know what to look for during our physical exams or during our laboratory exams too.
It is very important. Sometimes the patients do not like us asking so much, but
Right.
without realizing that asking will tell us again 50% of your diagnosis. Then the other 50, lab, physical, and there you go.
Some people get upset when you see them for the first time and they're coming in for a sore throat and you're asking them about their gynecological history, for example. But we need to have a complete history for any future visits as well. It might seem like it's a waste of time, but it's useful information for us.
Oh, you will be grateful on the long run to at least talk about that and leave it on your medical file, because you never know what's coming, and that information is very important. A simple measurement of your blood pressure, your heart rate stayed there. So, let's say, for example, 5 years after that, your blood pressure is high. Okay, we know we can estimate at least for how long this has been developing. So it is
To
very
be able to
important.
say, okay, so if it was fine 5 years ago and then maybe last year it started to go up a little bit and then this year is off the charts high, then you could say, okay, well, we better look at your kidneys, we better look at your heart,
all of the risk factors.
all the risk factors that go along with having high blood pressure.
Yeah, exactly. Now that you mentioned that, I always for my patients 50 and up, I ask for a baseline EKG. So that is crucial, especially if you come one day with a chest pain, or heart burn that it's not really a heart burn.
Right.
So
Shortness of breath.
Exactly. So having a baseline EKG, as the other laboratory tests mentioned, it is crucial. It is very important. You might not need it ever, but you might. This is like an insurance thing. It's better to have it not need it.
Right.
And need it and not have it.
It's kind of like having a baseline laboratory. Then we know, okay, this is basically your normal values when you're feeling well, and this is your value when you're sick. Because some people, their white blood cell count runs low, and that's just normal for them.
Correct.
So then when we look at it, we're not freaking out going, okay, what's going on here?
Exactly. And then going through a whole specialized blood test that they're really expensive.
And then they remember, oh, wait, but now I remember that for my whole life, they've always told me I have low counts.
Exactly.
And
anemia, things like that they're already even diagnosed.
Exactly. The other thing that's important when you go to your first appointment with a doctor is to bring all the list of your medications and how you take them.
Yeah, the list of medications in this case, when we have, as we have a lot of foreigners, the names, they change. So it takes a little bit on the consultation to look for the main ingredient, the principle, and then look for a similar or the same one even here in Panama. Unfortunately, there are some medications that you will never find here in Panama. So we have to try the best to pick the best one, and sometimes it's kind of hard to tell the truth. So I understand why some expats before coming there doing the research, and that is very, very important. Some of the ones that have done it, they've asked their physicians on the States to change their medications to something that they know that we will have here, and that takes a little research and calling and asking for prices, etc.
Otherwise, on our end, it's trial and error. We try out different medications to see, okay, will you do well on this one? Is there a specific reason your doctor had you on that particular medication?
Exactly. Yeah, because, I mean, there are, for example, many beta blockers, but they do not work the same way and for the same indications. So you have to be very careful. Not because they're beta blockers, that means that they all have the same target or the same purpose.
Right. Some tend to lower your heart rate a lot more than others.
Yes.
And if you already have a low heart rate because you're in heart failure or something like that, that can be pretty dangerous to give you a certain type of beta blocker.
Life-threatening.
Life-threatening, exactly.
You know, one thing I have found out as a patient a professional patient,
Professional
is,
patient.
is everywhere that I've lived in the world. I have to be very careful about things that I feel because I've got Parkinson's, diabetes, cancer, blah, blah, blah. So when I go see a new doctor, I have one statement and one question. I tell them how I'm feeling, and I ask, what do you need from me? Because they're going to be able to tell me, and I also carry my medical records. You know, I've sent you a book.
Yes, you sent me a book.
And if you're an expat, especially if you're on Medicare in the States or the insurance in Canada, you have access to digital copies of your medical records. Put them on a thumb drive, even if they're in English. When you go to your doctor, if you can just hand them these are my medical records. Everything. Mine go back 35 years or something. With every medication that I take, how I take them, when I take them, past diagnoses, and I want my doctor to have all this information. And then when y'all ask me a question, not wonder why, right? Or not say, why do you want that information? I just take it for granted that when my physician asks me for something or sends me for some labs or wants more information, that they're doing it in my best interest.
Right.
That they want me to get well or at least have something treated.
Right.
So to me, it's very important what you had said is to make sure you give your doctor every possible information and answer every question.
Right.
And understand that
As of
they're
the
trying to heal
files
you.
that you're saying from the States, I've had different experiences. I've had centers that they send you a very objective resume. We appreciate it.
Yeah.
Thank
Yes.
you very much.
Yeah.
Because if you send us
The
50 pages of documents, it takes a while for us to go
It
through.
takes time.
Yeah.
That's
Yeah.
more than a consultation.
Yeah.
Sure,
It is more than that. So, and there are others that they have their rules about the privacy of the information. So
yes.
they send us the file with 3 days of being there, and then after
And
that
then it disappears.
it disappears. There are some places that don't do anything.
They won't fax. They won't.
They won't
send,
do anything.
Yeah.
So it's a responsibility of the patient, at least to ask for a resume of the case, and maybe copy of the last 2 years of blood work or something that
Right.
you consider that was important in your medical history.
At least the most recent blood work that you had before you came here, is that there's some kind of a baseline.
And that's
Exactly.
why I carry my medical records with me because I have the authority to give that to whoever I want.
Right.
And I think I added you as my
did.
physician on one of my accounts.
You did.
So you can just. My point is that anything that you can do, right, in order to help the person trying to heal you,
Yes.
is in your own best interest. And I understand how that goes with the HIPAA in the States. Sometimes you got to wait 3, 4, 5 days to get the records in.
Yeah.
And we have access to that, to our own records.
Yeah.
So it really would be in our benefits is to be able to hand you a thumb drive or hand you a folder, say, here's
Exactly.
everything. You have it right there in front of you.
That is really greatly appreciated.
Here it's different. Here we have trouble getting records from other offices. We have.
Yeah, it depends on the politics of every clinic. And we, for example, as I told you, getting back to all the history of the patients, that takes time. But we do it. That is an extra appointment, of course. But when the patients need to go, we do the resume. The blood work, right now we're digitalizing everything. And we're giving back the blood work to the patients, all the tests. We're digitalizing
It's hard to
everything.
keep it in their files because it gets to be so much. It consumes so much space in your office and your file.
And at the end of the day, the patient paid for it.
Right.
So it is yours.
It's your studies.
It's yours to take. Now, there's another different thing, if you want to translate it. If the physician in the States doesn't speak Spanish, that I've known others that say, oh, don't worry, doctor. It's in Florida. They speak Spanish. So,
And they
again,
get the only doctor
great.
that doesn't speak Spanish.
Again, greatly appreciate it. But yeah, that's something to keep in mind when you're doing this change in your life of getting overseas.
Right.
Please always, even though if it's just a little thing, just high blood pressure, just
Right.
allergies, bring something with you.
At least have your doctor write up a summary of
Exactly.
the most important things and your medications. And like you said, if it's a medication they might not have here and you're already communicating with a doctor here in Panama, and there's a substitute for it here, ask your doctor if they can already switch you over before you come.
Exactly. That is a work and due diligence that you want to do before.
Now, when we're talking about preventive medicine, it doesn't mean that somebody that already knows they're diabetic or already knows they're hypertensive is not included in preventive medicine. They're still included.
No, I mean, you can be diabetic and still prevent, because there are so many things that can happen. The ideal scenario would be being healthy and doing a checkup every year like I do. Well, recently this year I started having my head physician for some other reasons, but religiously every year I would do all my tests to check the metabolic panel, as you call it. That's the way that you should start. Like you mentioned, like in the kids when they're growing also, you want to do this every year. Then if you are hypertensive or you are a diabetic, there's so many other things that you can develop. I mean, you can get retinopathy, neuropathy, all of kinds of different complications, like Mr. All here.
Yes, we have an example.
Exactly.
Bad patient.
I know.
So again, every year there are things that are like tests. There are like little windows to your body, like say the proteins on your urine.
Right.
For example, fundoscopy, that's looking at the retina in your eyes. Those are little windows to estimate how the rest of your arterial system is working, your cardiovascular system is working, and then we can take measures at a good time. And it could be behavioral measurements, because I know most of our patients here do not like medications. I understand it. I respect it. Me in particular, I like to use minimum necessary. But when I estimate that it's necessary, we can do a very, very low dosage of it, plus the behavioral changes.
Right.
And then maybe you won't suffer from that, let's say from the nephropathy, ever in your life.
And just because we put you on a medication for your blood sugar, once we put you on the medication, that doesn't mean you can go and start eating a whole bunch of carbohydrates and sugary things.
There are many behaviors here that the patients take. They take, for example, that let's say the patient comes very decompensated and we start on insulin, and they say, no, I don't want insulin because I'm going to use it for the rest of my life. You don't know, and we don't know.
Right.
What we do know is that you can do the behavioral changes, and maybe you will get out of it. I've had many patients gone out of insulin and even
all diabetic medications.
The diabetic medication, but they put their effort into it.
And that's where preventive medicine comes in. To prevent, we get some pre-diabetics. Pre-diabetics is somebody that's on the borderline. They're heading towards becoming diabetic. We might either only recommend exercise and diet, or we might also recommend, before you become diabetic, to put you on something to keep your blood sugar down, that later we can withdraw as you lose the weight, as you change your diet, to prevent you from progressing. Because once you progress, it's really hard to...
It is really hard, and when I see these patients, borderline patients, I try to make them understand that when you are diagnosed with diabetes, it's only a matter of numbers in your lab. But right now that you're borderline, you're having the same changes that a diabetic patient is having. So you have to take action right away, because it can get very complicated.
Well, you know, and I can attest to this, and Shannon helped me out with this. I was one of those people who were like, okay, I'm taking metformin, right? So I can eat what I want and then take the pill.
Twinkies.
And actually, I got that advice from a
Twinkies.
pharmacist in the States.
Oh,
He's like, yeah, I
wow.
just eat whatever I want and then I take a pill.
No.
Well, I have been doing that for
Doesn't work that
years.
way.
And like a lot of us have gotten very lax in testing, right? Because after a while, your finger was like a pincushion. So one day I had checked my blood pressure and my meter was very polite. It said, hi, which means I was over 600.
Blood sugar, yeah.
Right? I was over 600, and
It wasn't saying hi.
I know, right? So I had gone to Dr. Shannon, and she said, okay, here's what you need to do. First thing you need to do is stop eating a bunch of chocolate and then taking a pill. And I would say, what was it? Probably within about maybe a month, sick 3 weeks, 4 weeks in a month, listening to her.
He became hypoglycemic.
Well,
He went the other way.
But I eventually balanced out to where now I don't do that anymore because I understand that the pill, the metformin, is not a substitute for a box of Twinkies or cupcakes. It's and thankfully, you know, I do okay keeping up with that, but my blood sugars now are stable.
Yeah, he was doing so well that he actually cut out all carbs, all sugars, kept taking his medications, and then went.
I'm glad that you mentioned that because I've heard that story before from patients that come, let's say from outside Panama, and it just, I cannot believe it. For me, it's impressive because the main biggest studies that has been done in the medical field for diabetic patients, the UCA-PDS, the first intervention that they do on the patients is the eating habits. The eating habits.
Yeah.
And I don't see that happening in those patients. And the most frequent thing that I get from them is that they never went with me through the eating habits. They never sent me to a nutritionist. And that is the first step. No matter if you're gonna end up on insulin or hypoglycemiantes oral, hipoglycemiantes orales, doesn't matter.
Well, that's the first thing
step.
that Dr. Shannon did.
That is prevention.
What are you eating?
Yeah.
And I told her what I was eating, and after we picked her up off the floor. That was her first.
After I put my jaw back up.
And that was her first line of that. But you know, a lot of expats, particularly those from North America, we're very stubborn. We want to eat what we want to eat. You know, we want to have cake and cookies and chocolate and carbs, and we want to. We still think we're 20 and 30 years old. And, you know, the biggest cause of injury to middle-aged men and older men is
wives?
not realizing that they're middle-aged men and older men. We can't do this. We can't eat the way we used to.
No.
We can't, we need more exercise and watch our diet. And I have to tell you that you were the first one. I've seen a lot of doctors whose the very first thing that she did was, what are your eating habits? And here's what you have to change. You change this and then come back.
Down.
Yeah.
This is what
You were
get.
taught well. I wonder who did.
I wonder. I trained part of my time with you.
Yes,
part of my
exactly.
time with Dr. Chen. I was trained very well, I
Yeah,
think.
I'm glad to hear that.
I thank you very much for my
My pleasure. My pleasure.
for being part of my formación.
Okay. And the other thing that I see a lot that I wanted to address today about the preventive part is that sometimes when the patients, a lot of them, they tell me, no, I've been healthy all my life. And it's understanding the process of aging. You have to be aware that there are gonna things that change. And it's not that you're sick, it's just the process of aging. And you have to adapt. It's like getting pregnant, menopause, andropause. And you have to be
Andropause?
aware, there's andropause for the male.
Oh, I thought it was menopause.
Well, in Spanish, it's andropausia. Yeah,
What is this? What is this?
Andro. I heard under.
Andro.
Andro.
A-N-D-R-O.
Yeah, got it.
I need to Google that.
Yes.
I'm
So,
going to do that now.
so you have to be aware that there are going to come the changes, that you have to be aware and be open-minded that, okay, there are things that are going to change. I'm going to have to do different. Like, for example, the eating habits, as Mr. Al mentioned. I'm not 20-something anymore, but I can do better and still not sacrifice the goodness of my meals. And let's say that you get one of these symptoms. Let's say you get dizzy. The patients go directly to a neurologist. Or they go directly, I don't know, to the ENT. And they will discard what is in their knowledge.
Right.
But they won't address you as a whole. Then maybe you will be losing precious time on this. Now, let's not talk about the payment, the money. Let's talk about the precious time on this.
Right.
So you have to be aware that you need a head physician, somebody that is gonna see you as a whole, and they're gonna discard all the metabolic causes. They're gonna give you a full checkup. If they can solve it, they will. But if not, they will guide you in the right direction. So that is a very key person to have in your medical field.
Whether it be internal medicine or just a general
It
practitioner.
could be the general practitioner that you trust, that you know that does a good job. It could be an internal medicine. It could be a family medicine.
Geriatrician. If
Geriatrician. Me in particular, I get the hard stuff. Somebody tells me.
You're welcome. I send them to you.
Oh, thank you. I have a patient that calls me the big guns because that's what I get, the difficult cases. But
They come to me first.
yeah, exactly. But whichever you choose,
Yes.
you make sure that sees you as a whole, and then be guided to the right direction, especially not to lose precious time.
Now we've already talked about, okay, get a doctor to check out your blood pressure, check you over, do a full head to toe examination, but we are also leaving some other important things like mammograms, Pap smears, colonoscopies, and you already touched on the electrocardiogram. Electrocardiogram, depending on the person, they might need it every year.
Yeah, it's an interesting topic. It's interesting topic because especially the tubes going in and out of your body. Nobody likes it.
No.
But it's a must. It usually starts at 50 unless you have a trigger factor that then you have an indication to do it before.
As colonoscopies.
The colonoscopies, exactly. But yeah, you have to set in your mind that those are things that are coming. Recently, I had one. Let me tell you, it was a beauty. I didn't notice. Really. I asked the anesthesiologist, what are you giving me? And she said, midazolam and fentanyl. I'm like, oh, great. So
that's what you said after you got it, too.
No, after I got it. I just heard, like, okay, we're finished. I'm like, oh, I didn't even notice. Thank you. I was thanking them.
Thank you for putting that up there.
Yes, exactly. So it wasn't as ugly.
Right.
The ugly part is getting the cleanse. That is the ugly part.
Right, and everybody's read, little anecdotes about it. It's like, it's pretty much everything you ate since birth is forced out.
Exactly. So that's
I haven't had a French fry in 2 years.
Exactly.
But yeah, it's not as bad, as ugly as it seems.
Right. Like you said, the prep is probably the worst part. And then, of course, when you come out, since they load you up with air so that they can see, the air has to come out.
Exactly. You have some cramping here and there, but it's very, very tolerable.
Right.
As of for the mammogram, for example, you cannot rely only on the mammogram.
Right.
You have to do the 3. Yes, the 3. Mammogram, ultrasound, and physical checkup of your breast and the armpits, looking for lymph nodes.
And that's how I got a case just recently. Remember, the breast it's not only the actual breast, it's from the collarbone down.
Exactly.
I had a patient that had a little lump up on one of the ribs. But I don't know what that is. Is it a cyst? I had no idea. Sent her both for the ultrasound as well as a mammogram while she was at it. And it turned out it is something.
Yes, and the thing is that, again, there are patients that they don't like the radiation. But the sensitivity either goes up if you do the 3 or goes down if you do not decide to do the 3. And it's your life on the line. So you decide. We can give you the recommendations, but it's up to you to do it.
Well, I learned after only sending a mammogram and then it coming back as like a BI-RAD 0 and having to send off for a sonogram after that, I learned just send them both at the same time.
Exactly. Do the both and do the checkup. Exactly. That's your best screening pack. And what else did you mention? The Pap Smear. The Pap Smear. That should be.
The Pap Smear.
Yeah, that should be done every year. I say because, it's been 2 years of pandemic that I haven't been there. So
Me
I understand
too.
if you haven't, but keep
Me
it in mind.
too.
It's very, very important also.
Yes, it is.
For the male, well, we have good news for the males as the prostate.
Finally, good news.
Remember that it used to be a rectal checkup every year. Now it doesn't have to be that way. You can do the sequence of it every year, the PSA,
PSA.
the antigen for prostate every year.
The free PSA and the PSA and the
Exactly.
ratio.
So if we see that there is a increase on it, then you must go for the rectal. So because I've had patients like,
Right.
are you gonna do the rectal? I'm like, oh no, I have great news for you.
Well, it was supposed to be every 5 years in the States. Because when I turned 50, you know, my urologist said, okay, we got to do this. And I was like, well, okay. And then at 55 again, right before I came here. And now I'll be 60 in about a year and a half.
Exactly.
So now I did not even know that this was a thing.
Yes, those are the new guidelines that are right now, and they're
Wow.
guidelines. So for the guidelines, you have to be aware also that there are things that can change. There are some things that are established just for the medical field of people to speak the same language. Let's call it like that. But you have a patient in front, you have a history in front. You can change that if you consider that it's needed.
Especially urinary symptoms. Sometimes the PSA goes up really high
It
from
jumps.
being really low or normal, and you think, okay, infection or something else.
Exactly. Yeah.
So sometimes further testing is needed.
Exactly. And then you can, if it hasn't been 5 years, I mean, then you can do it. But yeah, right now it's follow up on the PSA, and if there is a pattern there, then you should go and do it.
It's much better that you get your PSA every year so that we can see if there's changes in
Right.
it.
Well, I'm going to have to do that.
Yeah.
Because I didn't know that was a thing. And there are so many of my friends here. You know, I'm considered young here. Most of the guys that I know here are in their 60s and 70s. And all of us, I mean, without exception, are on tamsulosin. All of it's not even just like, okay, well, you know, half of them, but everyone that I've met here is on that, you know.
Are they doing that as preventive medicine now?
No, I was thinking that's one of the things that changes with age, and it's not on. It's just for hypertrophy. And of course, if you have to urinate every hour, every night, you don't get any rest.
No.
If you have to push too much, if you get too many urinary tract infections,
Right.
that makes your life miserable. So yeah, I guess we go to that, but there's a high frequency on that in our patients. And the thing is that when you tell the patients, okay, you either have the option of doing a surgery, a resection, or taking the pill. Most
We're gonna
of them
take the pill.
decide the pill.
Yeah.
Exactly.
Yeah.
Exactly.
Yeah. And we're not as macho as we would like you to think we are. We'll take the pill. We'll take
No,
the
when you're
pill.
I
getting that
hear
little
ya.
scope going up there to check
Yeah.
things out,
No, I know.
I hear you.
It's-
It's not nice, and you feel it. In that case, you feel it.
Yeah.
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 So I
Kidney
understand.
stones, you'll feel it too.
Yeah, I've had 7 of those. Thank you.
Whoa.
7.
Water. Have you heard of water?
Well, now this is one of the things. Going back to the preventive. Shannon had asked me, you know, how much water do you drink? And I said, well, I drink a lot of coffee. There's water in coffee, and of course she yelled at me. So
Diuretic.
I'm drinking. I drink about a
Diuretic.
gallon, maybe a gallon or 2 of water a day.
There's an interesting fact happening here in Boca that since it's cool, people don't feel the drive to
Right.
drink water.
Right.
So you have to do a conscious effort on
Yeah.
drinking water.
Oh, absolutely, I do.
And in another note, talking about our wonderful coffee here, is that the coffee it's also a diuretic. It makes a transitory effects of rising your blood pressure that goes down, but it's also a diuretic. And there are people here that drink 5, 8 a day because it's so delicious.
Yeah.
Particularly, I found a syndrome for coffee, let's say excess, that patients have insomnia, they have involuntary twitching of the muscles, I call it the
Palpitations.
the palpitations, the headache, but it's not like this big headache. It's a
Just a low,
a
constant.
constant
Yeah.
headache there. And it is not described. This is a thing that is not described.
Yeah.
But I'm sure in other coffee producing places you will find it.
I
and
think our
just-
coffee has more caffeine than
Oh, I don't know, but the ones
the
I
commercials.
took
in
a
the States.
Folgers and my headache was roaring.
Yeah.
And that's from the States.
Yeah.
So
True.
yeah, you have to be careful. I know the smell every morning, every day from the plantations. It's wonderful, but you have to learn to manage a little bit your
If
intake
you have high
of
blood pressure.
Well,
if you
caffeine is
have
also caffeine.
arrhythmia.
Is
Exactly.
caffeine addictive? It's got to be,
It's addictive.
because I was at
Caffeine,
one
yeah.
point.
Depending on the person.
Yeah, so depending on the
Yeah.
person, getting out of it is hard. I had to go out of it, and I had headaches from going out of it.
We used to have 2 coffee pots. This is in the States. We had 2 coffee pots on our kitchen counter, 2 12-cup coffee pots, full size. One was for my wife, and my daughter was living with us, and my mother-in-law and everyone else in the house. And one was mine. And I would start my day off with a 30-ounce Yeti, and that holds 6 cups. And I'd fill that up twice before 10 o'clock in the morning. And then in the afternoon, I make another pot of coffee. So I was drinking 24 cups of coffee a day.
Ooh. So are you sure it's Parkinson's that you
I
have?
know,
or
right?
is it just the overdose of coffee?
But I did.
Wow.
Now I'm down to I'll have a mug in the morning, and I won't have
That's
any
it.
other
That's
caffeine.
the
He's
ideal.
like-
And I'm
He's like
sleeping
mug.
better.
There you
No,
go.
it's a regular. We have his and hers mugs. Literally says his and hers. It should say Twitch but anyway. But now that I've gotten down, and that was actually one of your suggestions.
Yeah.
So now I'm sleeping better.
Yeah, and
I don't shake as much with the
Yeah.
Parkinson's, because that's already from ground zero. So I guess that goes back to the first line of defense is your diet.
it's your
Yeah.
diet, your lifestyle, your healthy lifestyles, and we also have wonderful chocolate. So
Oh, yes.
I've replaced that for chocolate, one a day, one in the morning. That's
One
and when
bar.
you're talking about one, you're not talking about a bar.
One king size bar.
No,
right? One of those-
She's talking about a square or two, little
Exactly,
squares,
exactly.
Yeah.
and the darkest chocolate is usually the better.
Yeah.
cocoa, yeah.
Uh-huh. You don't want the milk chocolate. The milk chocolate is basically sugar.
And
Yeah.
it depends on. That's why I said the small one,
Uh-huh.
because for everything you have portions. The thing is, when you overload with portions, you use just one portion of the brown sugar, for example. That's what I use. And there was something curious about my pregnancy that my smell, I call it the defense mechanism on pregnant women. It was refusing the replacements for sugar. Call it stevia, call it Splenda, call it whatever.
Had to be sugar.
It had to be sugar. So since then, I understood my body. And in that matter, I always use just brown sugar and the portion that it's the portion is actually a very generous portion. It's 1 tablespoon.
That's what
I only use 1 teaspoon.
It's
Max
very
two.
the sugar for me as a diabetic. I just overloaded. Everything had to be. 1 portion of Oreos was a box.
No.
Right, I get Frosted Flakes. I sit in front of the TV, open the box, eat the whole box.
That's
I
when you're
don't.
5,
I don't
okay?
put sugar in anything. Even my coffee. We have stevia, and it's I have a mug, and I put one of them in there, or I put 1 1/2, and Dave puts the other half in there. And it took a lot of getting used to. I wanted to give up because it didn't taste right.
It doesn't taste the same. It's
But after a while, though,
bitter.
your body acclimates to it, and now I don't add sugar to anything.
Ugh, that's
So I like to live.
My husband's
that's
also
just-
diabetic. He's found the sugar substitutes actually raises blood sugar more than just using a teaspoon of sugar in his coffee.
That's where I wanted to get. But everybody's different, so you will have to do, as you said, your trial and error and see which one fits better for you.
Well, it's also willpower too. I can't stop at 1 tablespoon of sugar. David probably can. I'm sure he's got more willpower than I do. He's married to you. I'm only kidding.
Yes, I cracked the whip.
But I can't. I found myself not being able. I take a sip. I'd add more, and the next thing I know, I'm back to 5 or 6 or 7.
Yeah, because I mean,
Yeah.
I had the same problem
Yeah.
with my husband. He was raised in an American family, and he was raised with the Oreo
Oh,
and
yeah.
the milk
Uh-huh.
at night before going to sleep.
Yeah.
And the portions actually was the whole package. I'm like,
Yeah,
no, no, no,
a whole
no, no,
sleeve.
no, no.
That's it. Yeah.
You're gonna learn to read the nutritional
Oh,
facts
no, it's
and
hard,
adjust
man.
to those portions, and you're gonna teach your kids better.
Yeah.
Because I call it his sugar meter.
Uh huh.
It's just out of the charts.
No,
The
we're
fruits-
like the alcoholic that takes the cap off and throws it away. Yeah.
And I said the fruits you get, some of them very sweet fruits here. No, it's not sweet enough. It's not sweet enough. I'm like, you have to adjust.
Yeah.
You have to
Fruit
make
already
that-
has enough sugar in it.
Yeah.
Exactly.
It's still going to raise your blood sugar. Diabetics tell me, I'm eating healthy. I'm eating all this fruit. Why is my blood sugar still high? How much fruit are you eating?
Yeah. 6
Oh,
pineapples, you know.
Yeah, a few
Oh.
apples a day and
You
a
need
banana
to
or
adjust
two.
to the portion.
Yeah.
Mm.
Like, half
Yeah.
an apple.
Yeah, so if you were raised like that, you have to do the job with your family. When I diagnose a patient, a diabetic and Social Security, I tell them, give an order, that is an order. Everybody has to eat the same quality at home because what you have, they're gonna end up having eventually. So it's your responsibility to teach everybody at home how to eat better. It is impossible for a whole health system to educate everybody by itself. But if you replicate this, we are doing something. We are getting the health out there effectively. Know that you're going to cook fried for him because he likes it fried and the other, no. That's not happening. And if they get mad, tell that it was a physician's indication.
Doctor's orders.
Yeah.
Doctor's orders. Exactly.
I say that a lot because some wives say, you know, they have like a tendonitis or something in their shoulder or in their wrist or in their arms, or they have a rash on their hands and they shouldn't be touching chemicals and washing dishes and cleaning the house. And I can't stop doing it. My husband will get mad. You tell them, doctor's orders. You cannot be doing this until your hands heal.
And the other thing that I just want to give you the good news is that yeah, because when I was
We like good news.
yeah, we like good news. When I was studying medicine, I mean, I think the insulins that we had were very recent. Now we have more stable insulins, and the good news are that there are pharmaceuticals working on oral insulins. So if
But
you
the
want,
insulins have teeny tiny needles now.
yeah, they have very very tiny needles,
Yeah.
and you don't have, if you get those of a very long existence, you will only have to do it once a day,
Yeah.
unless you're a diabetic type 1. That's another whole story.
Right.
Yeah.
But
Or the
hanging
new,
there, we'll get to better things.
or the
Yeah.
new what are they called? DP4, DP4.
Los inhibidores de la DPP4.
That's once a week
Mhm.
or once a month, depending on the type. We just got the
Exactly.
Trulicity. It's not an insulin.
It's not an insulin. I have some patients on it. Trulicity is the one with better price. They
still
still
expensive.
carry a cost, of course. But as I say, if you have the means and if it's your health, look at it as an asset investment. I mean, if you are cheap with your health, I don't know where you're gonna get, what that is gonna get you. But every medication, the first time that they go out, they have a protection of 5 years. This meaning that you cannot get generics.
Right.
But after the 5 years of protection, prices drop.
Yeah.
So just hanging there, do the best that you can with your lifestyle, what you're eating, exercises, so you get to see that.
And please don't complain about the price of going to the doctor or the price of the medications when I see you in the store buying your cartload of cookies and alcohol. And,
Oh yeah. No.
you
I've
know.
had that argument with other expats.
and it's not that I'm
Better
discouraging
choices.
It's
you.
like, yeah, you know, you're gonna. Look. I see you every day at the freight forwarder with the 7 or 8 Amazon boxes.
Wow.
You can afford the $20, $30, $50, whatever
Yeah.
it is to go in and see
Exactly.
a
Yeah.
doctor.
I mean, I'm not trying to come down on anybody. I'm not trying to, upset anybody. But when you think about what you're spending extra on going out to eat, on, alcohol, on, I'm not saying don't enjoy your life. That's fine.
Take care of yourself.
Take care of yourself first and then use the extra after you take care of yourself to do the stuff that you like.
Priorities.
Yeah.
And I have to I really need to give Panama props, right, for their campaign on smoking. When guys my age, everyone smoked. You smoked at the dinner table, you smoked in the airplane. My parents smoked, grandparents smoked in the house, smoked in the
I
car.
remember those times.
And I smoke, and I'm what you would call a heavy smoker, and I have tried, just like a lot of us have tried, every way. You pick away a smoking sensation that has that has not worked, but they work for others. So the only thing I can come up with is that somewhere deep down inside I don't want to, but it's such a powerful narcotic. even when I go more than an hour, I start getting jittery. Right? It's like anything else, and I really. Panama has done such a fantastic job with, I mean, the pictures on the packs of cigarettes. I don't know if you've seen those.
Yes.
I got here, I was like, what? I sent pictures to my family in the States, and my kids have been trying to get me to quit forever. And I have not been successful with it. And it almost seems like everything that we do to improve our health with the diet and exercise and all that, smoking seems to just level it, and really undoes all of the good that we do.
Yeah, actually, for smoking, you have to be off of smoking for 30 years to have the same risk as a person that hasn't smoked.
3 or 30?
I mean, 30. I'm sorry, 30 years.
30.
Did I say
30?
You said 30.
Okay,
You said 30.
30.
See, and I've been smoking for 47 years.
Yeah, so there's a challenge there, and there's always a willpower thing on the beginning of anything.
Every day that you quit, your lungs get a little bit better.
Yeah.
But you know what? I found out that the exercising, especially here with this scenarios, look, today we have sun out, makes your endorphins out and make you feel
It
better.
makes you feel good, yeah.
Last time I tried to quit, about a week into it, my wife came home with a carton of cigarettes and said, "I will kill you before these do."
I did something like that at home.
She's an enabler. She's an enabler.
No. Oh, I thought she was throwing them away. She was giving
No,
it
she
to
was
you.
getting
Giving
it.
him
Yeah,
so that he wouldn't get- so that she
Let's
wouldn't
just say
have to
I was.
kill him.
Let's just say I was a little cranky.
I gave
You're a
an
little
ultimatum
cranky.
in my house. I
Yeah.
threw them away, and I gave an ultimatum.
What you have to do to be able to start limiting yourself is she has to put things like you cannot smoke in the car, you cannot smoke in the house.
Well, it
you have
doesn't
to-
help that she smokes too.
Oh.
Well, then she needs to do the same things.
Uh-huh.
You have to make a rule where you have to
Yeah.
walk 3 blocks to be able to have a cigarette.
Outside the house.
Outside the house.
Yeah, that
in
I
the
thought-
rain.
But
I
it's
thought
so
you were gonna
bad.
mention that because here you cannot smoke in restaurants
Nowhere.
and nowhere.
No,
You
not
cannot-
even outside the restaurant.
Yeah, no,
You
you-
basically have to go to your car.
Exactly,
Yeah.
and that
Yeah.
is a good thing that
I think it
Panama
is
has
too.
done.
I think it is a very
Exactly.
good thing. I hate smoking. I can't stand it. It everything smells. Difficulty breathing. It's just it's
Have you been to Spain?
not in 40 years. No.
Everybody smokes and everything smells like that.
Yeah, but it's terrible.
That's
you know,
terrible.
anyone who tells you, I really enjoy smoking, they're lying to you. It just there's nothing about it that is pleasant, and there's nothing about it that has any. There's no redeeming qualities at all. It's like one of the worst things you can do. But yet here we are.
40-something years later.
48 years
addictive.
later,
It
yeah.
is addictive. It's an addiction, and it
Right.
needs some help.
And that's one of the screenings we do in the preventive medicine is alcohol screening, smoking, and also illicit drugs.
Drugs, exactly.
But smoking and alcohol use are two of the main screenings that we look for because obviously with both of those you have an increased risk of cancer, different types of
Absolutely.
cancers, and also behavioral issues
Yeah,
and addiction issues.
absolutely.
The alcohol problem also. We have a lot of patients with cirrhosis, fatty liver, and then impaired metabolism of all of the medication. I've seen patients with coagulopathy, that's mean consuming all the coagulation factors, all
Right.
the platelets, because ulcers in the stomach, you do the clot, and then the declotting, and then it becomes a really big trouble.
A big
with
risk
alcohol.
of bleeding.
And then some patients feel that they do not drink much alcohol, but in reality, when you do the count, they do.
Yeah.
And it is very important in our history too. We do not ask for drugs to judge. Some patients feel like we're intruding or we're gonna tell the police. This is private. This is part of your medical history. But again,
This is
it's
just for us.
for
our
us
use.
to know and try to relate with what you're bringing to the table
Yeah.
that day or later on.
Because we need to know if you have liver issues. If we're seeing something on your blood work that's showing, okay, something's off with the liver, and then we find out, okay, there's a lot of, you take a lot of medications and you're also drinking a lot, then we know why.
Exactly, and those are little points on our medical history that you will see some faces like, why do you want to know my sexual habits?
Sure.
Why do you want to know if I have some other partners? Don't worry, it's not going to come out of there.
Right.
Yeah.
Unless you get an STD. Somebody's going to find out, but
They're going to know.
they're going to know
All by themselves.
But again, these are things that, believe me, it's not our personal interest. It's to try to help you. And the other thing that I ask the patients is, are you vaccinated? And sometimes I look at them like, I really do not judge about that. It's just that I need to know, because to tell you the truth, sometimes I have to take out my mask because I cannot breathe. So, but if I see, I have a patient in front that hasn't been vaccinated, I know that I cannot do that because I put them at risk.
Right.
I know that I'm at risk to even having my vaccines, but it is something that is, or if you have your vaccines and you're having palpitations, you're having pain on your legs, you can have secondary effects from the vaccines too. So we need all of that information.
Exactly.
It's not judging, it's trying to connect the dots.
The same with other medications that people are taking at the moment to try and prevent or treat COVID, like the ivermectin. I've had patients come in and they're not able to sleep, they're feeling jittery, they're having palpitations. I ask them, what are they taking? I'm not taking anything, nothing at all. No. Oh, well, I've been taking ivermectin, but just once a day, every day. And then you know.
That's a lot.
Right, because normal dose, for COVID is off-label, obviously.
Yes.
It doesn't have a dose at the moment. A normal dose is a one-time dose according to your weight. We're not giving it every day for scabies and that kind of thing.
No.
More than, one single dose is going to have some side effects.
Exactly. Yeah.
Especially if you're on the one that's made for
animals.
For animals.
Yeah.
I can say I'm almost 50 and I know some medical history. And at the beginning, ivermectin was only for animals. Time passed and they adjusted to human consuming. But it, as every other medication, it has its risk. So you have to follow what people have been using safely.
Right.
And using it every day is not indicated.
Right. No, don't use it every day. We don't even give it to our own pets every day.
No, poor things are going to die if you do that.
Right.
And they're talking a little bit about that, getting out of the topic of the preventive. There are different studies that show the use of high dosage of ivermectin. I do not use that. I do not recommend that. We try to stay on the middle. And again, if you want to use it, I'm not judging, I'm not recommending, I'm not saying do it or not, but if you decide to do, because these are personal decisions, just be safe on the dosage.
Right. And probably using it every day is not the way to go.
No, definitely not.
Not the way to go. Not unless it's directed by a doctor.
I doubt that
But
somebody's
even
going to
a doctor is not going to tell you to take it every day either.
Usually.
Definitely, unless the doctor wants you dead, that's not going to happen.
Right. Be very careful, because even though it's an extremely safe drug, it's extremely safe in the correct dosage and for the correct medical problem.
Correct.
Until we're told otherwise by the
Exactly.
studies, which are being done at the moment.
Exactly.
That's way off topic, but just a little public service announcement.
I don't think it's off topic at all, because I know plenty of people that are taking ivermectin,
As
hydroxychloroquine, zinc, or as
they're doing it
azithromycin,
for-
Yeah.
and they are doing it as a preventative, specifically, for COVID. And even though it's not the recommended, obviously preventative, this is what they're using it for.
Right. Well, I don't say anything against taking zinc, against taking vitamin D, against taking vitamin C or vitamin A. Those are all fine. The only one I worry about is vitamin D, because it's liposoluble, which means it doesn't get excreted. The excess does not get excreted.
You can get hypervitaminosis. That's what I was going to mention. So
Yes.
you have to, all of them you have to use on the right dosage. And actually, I've read about a lot of elderly patients with pneumonias having low levels of vitamin D. So if you use it on the right dosage, and we have 1,000 units, 2,000 units, 5,000 units.
Right. It gets very confusing on the labels.
Yeah. So you shouldn't be worried about secondary effects.
Well, this is why you go to your doctor. This is again. This is how we started.
Yes.
This is why you go to your doctor and you say, "This is what I'm feeling. What should I do?" And if they tell you, if your doctor tells you, "Do this, 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 and this," and I need to know this, and this, you tell them what they need to know, and you follow their direction.
Yeah.
I didn't go to medical. I'm not that kind of doctor. I didn't go to medical school. I have no clue how to take care of myself. Outside of the normal stuff.
Yeah.
This is why I go see Shannon.
Some patients go to Dr. Google.
Right.
Oh,
and
yeah,
they start
right.
looking
There
up.
you go. There it is.
Right there. And they start looking up how much vitamin D should I take as a preventative or for lung illness. And that's completely different. That's a patient that's hospitalized. Those indications are for hospitalized patients under medical supervision. The one that you take in your house is going to be, if you take a multivitamin, that already has it. That is probably enough unless you're really deficient.
Exactly. Yeah. And for the Dr. Google, sometimes there's some things that can be very confusing.
Oh
Yes.
my gosh.
I've had patients confuse a parasite with a bacteria because they both end in coli, but the E is different.
Right.
For example. And it can get very confusing. It's a source of a lot of good information. Actually, I like my patients to be informed.
Yes.
You have to know about your condition.
We only have about a minute left.
Okay,
So
good.
go ahead and
But
get your
again,
best points
it
in.
doesn't replace the knowledge of your head physician, especially if the doctor has experience. Because I'm not talking about bad about the new ones. They have the knowledge, of course, and
We know
messaging
something.
information. It's always coming. New information is always coming, but please do not take these decisions by yourself. Visit your head physician.
Right. And if I tell you I've got to refer you on to a specialist, it's because a specialist knows better than I do. I know a little bit about a lot of stuff. And I can tell you where you got to go if I don't know the answer.
Exactly.
I'm not going to make something up for you. If I don't know, I'm going to send you where you need to go to find out.
You tell me where to go all the time.
I know, but that's for a whole different show. Well, I would like to thank my guests today, my co-host over here, Al Stefanelli. I'd like to thank you, Dr. Digna Diaz, for being on the program today. We'd love to have you back another day to talk some more with us. I'd like to thank Veronica down in David, and of course, over here, Bolivar, our engineer. We'll see you next week. Thank you very much for joining us.
Thank you. Bye-bye.